Well, good afternoon, everyone. My name is Nora Spencer-Lovell, and I'd like to welcome you to today's CDC Partner Update on COVID-19. This call serves as a way for CDC to share weekly updates on COVID-19 and our latest resources and guidance, and to answer questions submitted by participants. On today's call, we'll discuss On today's call, we'll be discussing when to clean and when to disinfect, what we lovingly call fomites. First, we will hear from one of our science officers on CDC's COVID-19 emergency response. We'll describe where we are in the response and give us insight into recent scientific findings. And then we'll hear from an expert in the waterborne disease prevention branch on an overview of cleaning guidance for homes and community facilities. And afterward, our speakers will answer questions we received over the last week via email. Although I know we had live questions several weeks ago on the spur of the moment, but we won't be taking live questions today because we have quite a few submitted via email. So please feel free, if you have questions, to send them in and we'll get to them on the next call. For more information about these webinars, visit CDC's COVID-19 weekly partner call webpage, where you can register for future calls and see recordings of previous webinars. If this is your first call with us, welcome. These generally occur Monday at 3 p.m. Eastern Standard Time. Please see the link in the chat to subscribe and receive future call invitations. And please note, although this call is not intended for media, you are certainly welcome. Please, if you're a reporter and have a question, reach out to media@cdc.gov. They can help you out. All right, as I mentioned, these calls are designed to share the latest science, guidance, and resources from CDC. Now, as you know, CDC has issued thousands of resources and guidance materials for individuals, businesses, and the public on their website, cdc.gov. So here are some highlights of a few recent additions on our website. The first, CDC is launching a new webpage, Health Equity in Action, for visitors to learn more about CDC's collaborative efforts to address health disparities among populations at higher risk for COVID-19. CDC and our partners are committed to reducing the disproportionate burden of COVID-19 among populations at increased risk for infection, severe illness, and for death. Health Equity in Action highlights some of the multiple CDC efforts in place related to COVID-19 from across CDC's response and partnerships. And these projects align with the health equity strategy by CDC and offer web page visitors examples of CDC efforts to improve the health outcomes of populations disproportionately affected. CDC prioritizes opportunities to address these health disparities, and to help the United States succeed against this public health threat, CDC is working with state, territorial, local, and tribal authorities, community serving organizations, and public and private groups to ensure all public health efforts address the specific cultural, linguistic, environmental, historical, and other needs and priorities of each population. We continue to engage in collaborative projects where people live, learn, work, play, and worship. This page provides health equity resources and connections to some of CDC's relevant materials and efforts supporting communities at higher risk for COVID-19. And second, CDC has recently updated our website to include safety information about the Johnson & Johnson's Janssen COVID-19 vaccine. Last week, as many of you saw, in order to ensure safety and transparency, CDC and FDA recommended a pause in the use of Johnson & Johnson's Janssen COVID-19 vaccine. Of the nearly 7 million doses administered so far in the US, a small number of cases of a rare and severe type of blood clot have been reported in people receiving the J&J vaccine. All reports occurred among women between the ages of 18 and 48, and symptoms occurred 6 to 13 days after vaccination. Now, as of April 13th, no cases have been reported among the more than 180 million people who have received Pfizer or Moderna vaccines, which is a completely different type of vaccine than the Johnson & Johnson. COVID-19 vaccine safety is a top priority for the federal government, but frankly, for all of us. And all reports of health problems following COVID-19 vaccination are taken very seriously. This potential safety issue was caught early, and this pause reflects the federal government's commitment to transparency as CDC and FDA review the data. We do not know enough yet to say if the vaccine is related to or caused this health issue, But to be extra careful, CDC and FDA recommend that that vaccine not be given until we learn more. And this pause also will allow CDC's Independent Advisory Committee, the Advisory Committee on Immunization Practices, or also known as ACIP, to meet to review the cases and assess the potential significance. So ACIP met last Wednesday, April 14th, and they'll begin meeting again this Friday, April 23rd, to further discuss. All right, so today I'm pleased to be joined by two CDC experts. Dr. Cynthia Ogden is a science officer in support of the Chief Medical Officer on the CDC's COVID-19 emergency response. And Dr. Vince Hill is Chief of the Waterborne Disease Prevention Branch on the CDC's COVID-19 emergency response. First, I'm going to turn it over to Dr. Ogden for some general updates.
Thanks, Nora, and welcome everyone. I'm glad you're joining us today. My name is Dr. Cynthia Ogden, and as mentioned, I'm a science officer serving in support of the Chief Medical Officer for the response at CDC. And today I'd like to provide a brief update on the response and review some of the latest scientific developments. Next slide, please. Thanks. First, a situational update. You can see from the slide that national COVID-19 cases and deaths have slightly increased over the past week as compared to the previous week. As of April 17th, the 7-day average in cases increased by 1.7% over the previous 7-day average. The 7-day average in deaths increased by 3.3% over the previous 7-day average. Reported COVID-19 cases and hospital admissions have been on an upward trend since March 20th, 2021. So these statistics really do provide us with valuable information. When percentages are decreasing, this tells us that the mitigation efforts are working. When case counts increase, this tells us that we need to step up mitigation efforts to slow the spread of COVID-19. So on the vaccine front, as of April 18th, 209 million vaccine doses have been administered in the United States. About 131 million people, or 39.5% of the US population, have received at least one COVID-19 vaccine dose, and 25.4%, a quarter of the US population, are fully vaccinated. We encourage you to visit CDC's data tracker and the new weekly review for the latest stats and key indicators for the pandemic. Next slide, please. So in terms of some science updates, new this week, I want to share some of what we've learned from a few reports released in CDC's Morbidity and Mortality Weekly Report, or the MMWR. In the interest of time, I'm only going to touch briefly on the high points of these reports, and you will see the links to the reports in the chat, and you can visit cdc.gov to read the full reports. The first MMWR, entitled Laboratory Modeling of SARS-CoV-2 Exposure Reduction Through Physically Distanced Seating in Aircraft Cabins Using Bacteriophage Aerosol. In this report, scientists at CDC and the University of Kansas modeled COVID-19 exposures using various aircraft seating arrangements. They found that full occupancy seating increased exposure to the virus that causes COVID-19. With reduced seating, including vacant middle seats, exposure was reduced by up to 57% compared to full occupancy. Based on this laboratory model, keeping aircraft cabin middle seats vacant reduces the risk of exposure to the virus that causes COVID-19. So current CDC guidelines recommend against travel for people who've not been vaccinated and masks for all people while on aircraft. Physical distancing of aircraft passengers, including through policies such as middle seat vacancy, could provide additional reduction in COVID-19 exposure risk. So the second MMWR, entitled Emergency Department Visits for COVID-19 by Race and Ethnicity, that's the title of the second one. The data in this report show Hispanic, non-Hispanic American Indian or Alaska Native, and non-Hispanic Black people have higher rates of hospitalizations and death due to COVID-19 compared with non-Hispanic white people. Using ED data, or emergency department visit data, from 13 states obtained from the National Syndromic Surveillance Program, CDC assessed the rate of ED visits with a COVID-19 discharge diagnosis between October and December 2020 by age and race ethnicity. And so results showed that compared with non-Hispanic white people, Hispanic people were 1.8 times more likely to seek care at an ED for COVID-19. Similarly, non-Hispanic American Indian or Alaska Native people were 1.7 times more likely to seek care. And non-Hispanic Black people were 1.4 times more likely to seek care. So these differences in ED visit rates suggest ongoing racial and ethnic disparities in COVID-19 incidence. These findings can be used to prioritize prevention resources, including COVID-19 vaccination, to reach disproportionately affected communities and reduce the need for emergency care for COVID-19. So the final MMWR we'd like to highlight is on COVID-19 and influenza discharge diagnoses as a percentage of emergency department visits. In late June 2020 through July 2020, almost 3% of all emergency department visits in the United States were for COVID-19. Visits for COVID-19 then declined through August 2020, and a larger and more prolonged increase in COVID-19 ED visits began in September 2020 and peaking in early January 2021, with more than 7% of all visits from COVID-19. While influenza activity generally begins in October and occurs throughout the winter months, influenza accounted for less than 0.1% of all emergency department visits during June 2020 through March 2021. And just as a comparison, this compares to data from the beginning of February 2019, when the percentage of ED visits for influenza reached 5%. With that, it is now my pleasure to hand the call over to my esteemed colleague in the Waterborne Disease Prevention Branch.
Great. Thank you, Dr. Ogden. As mentioned earlier, my name is Vincent Hill. I'm the chief of the Waterborne Disease Prevention Branch, and I'm supporting the CDC COVID-19 emergency response as a senior advisor for environmental microbiology. Next slide. So SARS-CoV-2 transmission is complicated, especially for transmission of the virus from contaminated surfaces. In this figure from Public Health England, transmission pathways are illustrated. Often, it is not possible to isolate a single pathway responsible for a case or a cluster of cases. For the purpose of this presentation, we will focus on transmission related to surface contamination in the center bottom of this figure. Next slide. This adapted figure will show just the surface transmission route. For this transmission route, an infected person has normal respiratory activity, in other words, regular breathing, or may cough or sneeze, expelling respiratory secretions in large droplets in addition to aerosols and small droplets. Focusing on the large droplets and respiratory secretions, these can directly contaminate the infected person's hands or may land on surfaces in the area surrounding the person. Thus, virus may contaminate surfaces through droplets or when contaminated hands from an infected person touch a surface. Virus can be transmitted from the contaminated surface to the hand of a susceptible person when that person touches the surface. Virus on a susceptible person's hands can then be transferred to a mucous membrane in the eyes, nose, or mouth when the susceptible person touches their face. The person may then become infected. It is important to note that masks are a barrier that can reduce the amount of virus that might land on surfaces, and cleaning hands can prevent contamination of surfaces as well as the transfer of virus from contaminated hands to a susceptible person's face. Next slide. Transmission of the virus that causes COVID-19 by direct contact and inhaling aerosols and droplets is more likely than by touching surfaces. The same relative transmission risk is supported by scientific evidence for other respiratory illnesses, particularly for transmission of cold and flu viruses. Respiratory viruses such as SARS-CoV-2, shown in the image on the right, influenza virus, and rhinovirus, which causes colds, have an outer layer called an envelope, shown in the image on the right, and this envelope can be damaged relatively easily in the environment, especially outdoors where sunlight and heat can damage these viruses quickly. Respiratory etiquette, like sneezing into a tissue, and cleaning hands have demonstrated effectiveness for preventing respiratory illness. During the pandemic, CDC has collected data on unintended health impacts from increased use of cleaning and disinfection products, and heard many reports from partners and the public on challenges in following our guidance. Throughout the pandemic, the public has been able to get answers to questions by submitting them to CDC Info, which is CDC's National Contact Center for the public to ask questions of CDC experts and obtain publication resources. The most common type of hygiene-related questions that CDC has received have been related to cleaning and disinfection. These questions from the public often ask about how, when, and what products to use for cleaning and disinfection. Early in the pandemic, we heard from various partners that implementing cleaning and disinfection guidance was challenging, often due to a lack of availability of EPA List N disinfection products. List N is an EPA list of disinfectant products that EPA expects to be effective for killing SARS-CoV-2. In school settings, we have heard from administrators and educators that recommended cleaning and disinfection procedures were difficult to implement due to lack of time and competing priorities. There have also been reports of highly visible cleaning and disinfection behaviors, including the use of fogging sprayers, as shown in the picture on the right, that could be used as a form of hygiene theater or putting on a show of cleaning and disinfecting. Such cleaning procedures may be used to give people a sense of security that they are being protected from the virus, but this may be a false sense of security if other prevention measures like wearing masks, physical distancing, and hand hygiene are not being consistently performed. It also could make people feel less need to engage in these other important prevention measures. Based on surveys and public inquiries regarding how, when, and what to use to clean and disinfect surfaces, one of the consequences of frequent disinfection is that people may be using disinfectants in ways that are unsafe. Public inquiries indicate that some people may purposely drink, inhale, or spray their skin with disinfectants, without understanding that use of disinfectants in this way can cause serious harm to their bodies. Data from a CDC survey suggested important gaps in public knowledge and practice in the safe use of cleaners and disinfectants. For example, only 58% knew that bleach should not be mixed with ammonia because mixing bleach and ammonia creates a toxic gas that harms people's lungs. 19% wash food products with bleach, which could lead to their consumption of bleach that isn't washed off, which can damage the body because bleach is toxic. And 18% used household cleaner on bare skin, which can damage the skin, causing rashes and burns. In association with a dramatic increase in disinfectant use and gaps in public understanding of proper use and safety practices, National Poison Data System surveillance during the pandemic shows that calls to poison centers for disinfectants in 2020, shown by the black line in the figure, exceeded calls in 2018 and 2019, the gray and blue lines in the figure. The yellow line depicts calls to US poison centers through April 2021 and shows continued higher call volume for disinfectant exposures than in 2019 and 2018, although the numbers are lower than we saw in the spring and summer of 2020. Next. Using evidence from epidemiological and field investigations, experimental studies, and quantitative risk assessments, CDC completed a scientific review of SARS-CoV-2 surface transmission risks. Based on the findings from these sources of evidence, CDC determined that the risk of surface transmission is low and secondary to the primary routes of virus transmission through direct contact, droplets, and airborne aerosols. We found little evidence indicating that there is significant transmission of the virus from contaminated surfaces, which are also referred to as fomites. Although it can be difficult to distinguish surface transmission from other transmission routes. There are some case reports that suggest that people are at increased risk of surface transmission within the first 24 hours after a sick person has been in a space. One study of households in which an infected person was residing found that cleaning and disinfection appeared to be associated with lower transmission of the virus within the household. One of the important sources of information used in the science review were quantitative risk assessments. Quantitative risk assessments help us understand and characterize the relative risk of transmission and evaluate the need for and effectiveness of prevention measures. Multiple published risk assessment studies were available, and all of them supported a determination that the risk of infection from surfaces is low and generally less than 1 in 10,000, meaning that each contact with a contaminated surface has less than a 1 in 10,000 chance of causing an infection. The risk assessments use surface contamination data from indoor and outdoor surfaces. The risk of infection from touching a surface is generally less in an outdoor setting than an indoor setting due to harsher environmental conditions outdoors, like sunlight and heat. Wearing a well-fitted mask reduces the amount of respiratory droplets, and therefore virus, that can land on surfaces, and thus is a prevention measure that can further reduce surface transmission risks. Evidence also shows that hand hygiene can act as a barrier to transmission and thus further reduce surface transmission risk. In our scientific review, we looked at experimental data from studies investigating the survival of SARS-CoV-2 on common indoor surfaces. We focused on survival data under typical indoor conditions with temperature in the range of 20 to 25 degrees Celsius, or 68 to 77 degrees Fahrenheit, and relative humidity of 30 to 65%. Most studies reported the virus dying off rapidly on soft surfaces like cloth, with inability to detect infectious virus within minutes to hours. For hard surfaces like stainless steel, researchers generally found that 99% of the virus died off within 3 days, as depicted in the graph on the right. In this graph, the amount of virus, shown here using the word titer on the vertical axis, at the beginning of the experiments, at time 0, the data is shown in black dots in the upper left corner at the level of 10 to the 5 or 100,000 virus particles. As the virus particles sit on a surface, in this case on stainless steel, they become more and more damaged over time and lose their ability to infect. In this set of experiments, the amount of virus shown as dots decreases with time measured in hours. In these experiments, after approximately 72 hours, or halfway between the 50 and 100-hour time points, the dots are approximately 99% lower than at the start of the experiments. The straight green lines are a way of showing how fast the die-off is occurring. We looked at published experimental data for hard surfaces commonly found in homes and facilities like stainless steel, but also plastic and glass. And in general, these experiments indicated that 99% of the virus will die off on hard surfaces in indoor settings within 3 days. In addition to examining the relative risk of surface transmission, the scientific brief examined 2 of the main ways that we can reduce the risk of surface transmission after a surface is already contaminated, which are cleaning with household cleaners and containing soap or detergent, or using a disinfectant product registered with EPA's List N, which is EPA's list of products determined to be effective against SARS-CoV-2. Cleaning is the process of removing dirt and germs from surfaces, whereas disinfection is the process of killing germs on those surfaces. Cleaning and disinfection can both reduce the risk of surface transmission. I will describe a bit about how these processes work. Cleaning with a soap or detergent product reduces the amount of soil on surfaces, including dirt and germs like viruses. Soap and detergent chemicals are molecules that have one end of the molecule that is attracted to water, shown in the images as blue dots attached to squiggly lines, and the other end of the molecule that is attracted to organic materials like dirt and germs. Soap and detergent molecules create micelles, which are spherical structures that surround dirt and germs and help remove them through washing and wiping off a surface. Cleaning with soap and water or a detergent product made for surface cleaning can reduce virus levels on surfaces by 90 to 99%, depending on the cleaning method and surface being cleaned. For SARS-CoV-2, shown in the image with in black with spikes, soap molecules can also damage the virus. However, soap and detergent products are designed for cleaning, not for killing the virus, unless the products contain a disinfectant chemical, and are registered on EPA List N for products that are effective against SARS-CoV-2. Disinfectant products are designed with chemicals that cause damage to the outside or inside parts of germs so that they cannot cause infection. There are many types of disinfectants that are effective against the virus that causes COVID-19. To substantially kill the virus on surfaces, the surface must be treated with a disinfectant product registered with EPA's List N. Surfaces should be cleaned before applying a disinfectant so that the disinfectant can work well. If the disinfectant product does not already contain a cleaning agent, the surface should be cleaned before disinfecting. So in conclusion, the CDC science brief described some important findings on surface transmission of the virus. The most important finding is that the scientific evidence indicates that the risk of surface transmission is low in most situations. Mask wearing can substantially reduce the amount of virus from infected people that gets into the environment and onto surfaces. Hand hygiene and cleaning and disinfection can be effective for reducing surface transmission risks. When SARS-CoV-2 viruses land on surfaces, they rapidly die within hours on soft, porous surfaces. They can live longer on hard surfaces, but can be expected to die off by 99% within 3 days. Cleaning alone can be effective for removing virus from surfaces and reducing already low surface transmission risk. EPA List N disinfectants are highly effective for killing the virus. Disinfection of surfaces is warranted within the first 24 hours after surface contamination when infectious virus is more likely to be present. So now I'd like to talk about our updated cleaning and disinfection guidance based on the scientific review of surface transmission that I just told you about. Next slide. It's important to note that the science review and updated guidance are for community settings, not for healthcare settings or facilities that have specific regulations. Community settings include locations such as homes, educational institutions, workplaces, and other indoor or outdoor locations that serve the general public. As a general principle, in most situations, cleaning surfaces using soap or detergent and not disinfecting is enough to reduce the already low risk of virus transmission from surfaces. Mask wearing and practicing hand hygiene are also important for reducing surface transmission risks. In homes and shared housing, CDC recommends cleaning regularly, for example, daily, and after you have visitors in your home. Disinfecting surfaces is typically not necessary unless a sick person or if someone positive for COVID-19 has been in the home within the last 24 hours. When cleaning, focus on high-touch surfaces like doorknobs, handles, light switches, tables, and countertops. More in-depth disinfection in areas occupied by the sick person is needed if someone in the household is sick. Use products that are suitable for each surface and always follow the label instructions on the product. In community settings like offices and stores, in most situations, daily cleaning is usually enough to reduce any virus present on surfaces. Some situations may prompt more frequent cleaning or may warrant choosing to disinfect. For example, in settings where there's a high transmission of COVID-19 in the community, low mask usage, where hand hygiene is not performed frequently and consistently, and in places where people in the facility are at increased risk for severe illness from COVID-19. When cleaning, or disinfecting if needed, focus cleaning procedures on those high-touch surfaces, like handles, countertops, and store payment devices. Ensure that cleaning staff are trained and have the needed safety supplies. If choosing to disinfect, use EPA List N disinfectants and follow the product use guidance on the label. If a person who is sick or positive for COVID-19 is known or suspected to have been in your home or facility, follow these cleaning and disinfection guidelines. If the person is residing in the space or has been in the space within the last 24 hours, disinfect surfaces after cleaning. If it has been more than 24 hours, but less than 3 days, then disinfection is not needed, but surfaces, particularly commonly touched surfaces, should be cleaned with soap and water or detergent product. If it has been more than 3 days since the person who is sick or positive for COVID-19 has been in the space, no additional cleaning or disinfection is needed. Routine daily cleaning is recommended. Here are steps for cleaning and disinfecting when an infected person has been in a space within the last 24 hours. Before cleaning and disinfecting the space, close off the areas used by the person. Wait as long as possible to enter the room, at least several hours. While cleaning and disinfecting, ventilate the room by opening doors and windows and using fans or central air. Wear a face mask and gloves while inside the area. If vacuuming, use a vacuum that is equipped with a high-efficiency particulate air filter or HEPA filter. Thank you for your interest in CDC's recommendations for cleaning and disinfection and scientific assessment of the role of surfaces in COVID-19 transmission. If you would like to learn more about these topics, here are some available resources.
Thank you so much, Dr. Hill and Dr. Ogden. Both presentations were incredibly informative. And before we move on to the Q&A portion of the call, to our audience, please go ahead and take a moment to answer the questions through the poll on your screen shortly. Now, for those of you who submitted questions in advance of this call, thank you so much. We received so many, and we'll try to get to as many as we can. Do we have the poll control tower? There we go. All right, Dr. Hill, this first group of questions is for you. So the first question is, how has CDC's cleaning and disinfection guidance changed?
Great, thank you. CDC guidance has been updated based on scientific evidence indicating that in most situations, the risk of getting COVID-19 from touching surfaces is low, and that cleaning surfaces using soap or detergent is enough to further reduce the already low chance of COVID-19 spread from surfaces. The updated guidance only recommends disinfecting surfaces in higher risk situations, such as when there has been a sick person or someone who has tested positive for COVID-19 in a home or facility within the last 24 hours. Previously, CDC guidance recommended cleaning and disinfecting indoor spaces up to 7 days after a known or suspected COVID-19 case. Based on the scientific review, CDC's guidelines now indicate that cleaning and disinfecting is only recommended within the first 24 hours after a known or suspected COVID-19 case has been in an indoor space. If it has been more than 24 hours but less than 3 days since a known or suspected COVID-19 case, then only cleaning of the area the sick person used is needed, not disinfection. If it has been more than 3 days, no additional cleaning aside from regular cleaning is needed.
All right, great, thank you. Second question, how can I put the new CDC cleaning and disinfection guidance into practice in my setting if I'm concerned that I may have a higher risk situation?
Thanks. We've gotten this question a number of times. The recommendation to clean surfaces in most situations instead of disinfecting them is based on the weight of available scientific evidence. This evidence indicates that the risk of getting infected by the virus from surfaces and objects is low. The evidence also shows that cleaning can be effective at further reducing risk by removing virus from surfaces. These findings and others reinforce our understanding that the main risk of spreading the virus is from close contact with an infected person, not from touching surfaces. Layered prevention measures are critical for stopping the spread of the virus and include hand hygiene and surface cleaning, and in some situations, disinfection, along with a primary focus on vaccinations, wearing masks, and physical distancing. It's important to recognize that the scientific evidence is not sufficient to inform detailed surface cleaning and disinfection recommendations in specific settings and procedures. Based on the way the virus can be transmitted from surfaces, CDC's cleaning and disinfecting your facility guidance identifies conditions that can increase the relative risk of infection while recognizing that the risk of surface transmission is low. These conditions include high transmission of COVID-19 in your community, low number of people wearing masks, infrequent hand hygiene, or the facility space being occupied by certain populations, such as people at increased risk for severe illness from COVID-19. In these situations, facilities may want to develop plans in which more frequent than daily cleaning is performed, or choosing to disinfect in some situations. Ultimately, it's up to people setting cleaning plans to judge the nature of who occupies the space, what happens in the space, and any other potential risks involved, and to use that information to decide how often to clean or if they should disinfect.
Thank you so much, Dr. Hill. All right, this third question is the one you've all been waiting for. And in essence is, do I need to keep wiping down my groceries? But I'll read the full question. Is it necessary to clean food containers, food-related surfaces, and/or groceries? If so, what is the recommended approach? Friends of mine have been disinfecting food contact surfaces and groceries, not realizing this may leave a non-food safe residue on the surface of the food.
Great, thanks. So the risk of infection by the virus from food products, food packaging, or bags is thought to be very low. Currently, no cases of COVID-19 have been identified where infection was thought to have occurred by touching food, food packaging, or shopping bags. It's always important to follow good food safety practices to reduce the risk of illness from common foodborne pathogens. So in homes and shared housing, special cleaning and disinfection activities are only needed when someone is sick in the home. In these situations, caregivers should wear gloves when handling dishes and utensils for the person who is sick, and should wash the dishes and utensils with soap and hot water or in the dishwasher. If needing to disinfect a food contact surface like a kitchen counter, use a disinfectant product from EPA's list ad. When using disinfectants, always follow the directions on the label to ensure safe and effective use of the product. Before preparing food on a disinfected surface, the surface should be rinsed with water. It's also important to note that the CDC cleaning and disinfecting your facility guidance is intended for cleaning and disinfecting buildings and community settings to reduce the risk of COVID-19 spreading. This guidance is not intended for healthcare settings or for operators of facilities such as food and agricultural production or processing workplace settings, manufacturing workplace settings, or food preparation and food service areas where specific regulations or practices for cleaning and disinfection may apply.
Great, thank you so much. Okay, let's turn to disinfection in spaces used by kids. How do you recommend cleaning public playground equipment, public playground equipment and shared toys for young children at a community facility?
Great, thanks for that question. So CDC recommends that schools and community facilities for children use and layer multiple prevention strategies to reduce transmission of SARS-CoV-2, including good hand hygiene and mask wear. An additional strategy is cleaning and maintaining healthy facilities. High-touch surfaces on playground equipment, like grab bars and railings, should be cleaned regularly. For example, using soap and water or a household surface cleaner. Cleaning of wood play structures, like that, those natural wood play structures, is not recommended. For facilities serving young children and others who may not consistently or properly wear masks, wash hands, or cover coughs and sneezes, the relative risk of surface transmission is low compared to the risk of respiratory and direct contact transmission. However, it's still prudent to limit the use of shared objects in those cases and consider performing more frequent cleaning to the extent practical. As noted previously, CDC's cleaning and disinfecting your facility guidance identifies conditions that can increase the relative risk of infection from surfaces, including shared objects, while recognizing that the risk of surface transmission is low. These conditions include high transmission of COVID-19 in your community, low number of people wearing masks, and infrequent hand hygiene, which may be present in settings with young children.
All right, thank you so much. Turning now to the virus itself, how is SARS-CoV-2 survival different for hard surfaces versus closed? For example, if I sit on contaminated surfaces at a restaurant or someone sneezes and SARS-CoV-2 get in my clothes, can the germs get from my clothes to others in my family? How to disinfect clothes, is washing enough, etc.?
Great, this is a really interesting question. The virus will likely survive longer on hard surfaces than on clothes. Studies report being unable to detect infectious virus within minutes to hours on soft, porous surfaces like clothing, whereas on hard, non-porous surfaces like countertops, infectious virus can be detected for days to weeks. The relatively shorter survival of the virus on soft, porous surfaces might be due to the difference in how respiratory droplets containing the virus attach to pores, which you can think of as holes and passageways in a surface, which may cause them to dry up faster and damage the virus quicker. The risk of getting COVID-19 from touching clothes is likely very low in those situations, particularly if nobody is sick. In those situations, CDC recommends washing clothing and other soft items that can be washed in the laundry. If handling dirty laundry from a person who is sick, it is safe to wash the laundry with other people's items, but CDC recommends protecting yourself by wearing gloves and a mask.
Thank you so much, Dr. Hill. Okay, moving on. How effective are technologies that claim to neutralize or kill SARS-CoV-2, such as ozonated or ozone water, water tablets, electrostatic misting sprayers with UV light, etc.? Other than alcohol-based disinfectants, are there any other commercial chemicals that could kill the virus on hard surfaces?
Yeah, thank you. This is one that, there are lots of pictures about this, and it's a pretty visible question that people have. So the effectiveness of many alternative disinfection technologies against SARS-CoV-2, these alternative disinfection technologies, they haven't been fully established, the effectiveness, particularly under real-world settings outside of controlled laboratory conditions. In most cases, technologies using fogging, fumigation, and wide area or electrostatic spraying are not recommended as primary methods of surface disinfection based on efficacy and potential safety concerns. To find products that are effective disinfectants, EPA maintains List N, which is the best place to find a product. As of April 15th, more than 600 commercial products are listed there. And CDC recommends using products in general, using products that are shown to be effective against SARS-CoV-2.
Thank you. Okay, one more question for you. It's a doozy. There is concern across some industries such as food and agricultural production, manufacturing, workplace, or food service that CDC's guidance results in mixed messaging related to surface disinfection. So a whole system approach to pathogen risk reduction includes frequent cleaning and disinfection of surfaces, especially for controlling difficult pathogens with known fomite transmission routes, such as norovirus or hepatitis A virus. There is concern that the updated guidance implies that surface disinfection is not necessary in general, and that this could take away from controlling pathogens other than SARS-CoV-2. Can CDC clarify cleaning and disinfection related to controlling these other pathogens?
Great, thanks. I really appreciate having this question because it is important to clarify. So part of this question refers to food industries and food service. So it's important to note again that the CDC cleaning and disinfecting your facility guidance is not intended for operators of facilities such as food and agricultural production or processing workplace settings, manufacturing workplace settings, or food and preparation and food service areas, because those areas have specific regulations or practices for cleaning and sanitization or disinfection that may apply. And so those, nothing that we've put out supersede any of those kinds of regulations and practices that you've got potentially in those workplaces. The updated guidance applies to COVID-specific situations and does not supersede, these cleaning or disinfection guidance for other pathogens or regulated settings. CDC agrees wholeheartedly that cleaning and disinfection are important actions that the public and facility managers can take to prevent spread of infectious diseases.
Thanks, Dr. Hill, for the presentation and for those incredibly helpful answers. I'm going to turn now over to Dr. Ogden for the next set of questions. First to you is a person who has had COVID already likely to have antibody levels similar to a vaccinated individual?
So getting COVID-19 may offer some natural protection known as immunity. However, experts don't know for sure how long this protection lasts, and the risk of severe illness and death from COVID-19 far outweighs any benefits of natural immunity. COVID-19 vaccination will help protect you by creating an antibody or immune system response without having to experience sickness. Both natural immunity and immunity produced by a vaccine are important parts of COVID-19 disease that experts are trying to learn more about, and CDC will keep the public informed as new evidence becomes available. CDC continues to recommend vaccination for people who have already been infected with COVID-19.
Thanks. Okay, this one asks for your thoughts on the Brazil variant and its spread in the US.
So this variant, P1, it emerged in Brazil in the Amazonas state. The P1 variant shares some of the spike protein substitutions observed in another variant, the B1351 variant first seen in South Africa. P1 was first identified in the United States on January 25th in Minnesota, in one case with travel history to Brazil. but has also been detected in other states in individuals with no known travel history to Brazil, indicating the likelihood of community transmission. We have much less data about how this variant is spreading. The currently estimated national prevalence of the P1 variant is 1.4% for the 2-week period ending March 27th, 2021. There are regional differences in the prevalence of this variant. Based on data available to CDC, the state-level prevalence of the P1 variant ranges from 0.1 to 7.9%. We do not yet know if the severity of disease this variant causes is clinically different from other SARS-CoV-2 variants. Most experts believe it is likely to cause similar disease, with severity not being much greater than we are seeing now. We will continue to provide updates as we learn more about this new variant, and our guidance may change as we better understand it. CDC continues to emphasize the importance of compliance with public health measures such as wearing a mask, staying at least 6 feet apart from others, avoiding crowds, ventilating indoor spaces, and washing hands frequently. These are our best tools for preventing the spread of this virus, no matter the strain. There is evidence that this variant may spread more easily, so increased compliance with these prevention measures will be critical to slow its spread. And CDC continues to recommend vaccination as soon as the vaccine is available to you.
Thanks, Dr. Ogden. And I think as of today, that's for all adults in the US.
That's right.
Okay, third question. If CMS, Center for Medicaid Services, is opening visitations in nursing homes with moderate community transmission of COVID, is it still recommended to quarantine new nursing home admissions for 14 days and refrain these new patients from visits?
So residents with confirmed SARS-CoV-2 infection who have not met criteria for discontinuation of transmission-based precautions, you'll see a link for that in the chat, should be placed in designated COVID-19 care units. In general, all other new nursing home admissions and readmissions should be placed in a 14-day quarantine, even if they have negative tests upon admission. Exceptions include residents within 3 months of a SARS-CoV-2 infection and fully vaccinated residents, as described in CDC's updated healthcare infection prevention and control recommendation in response to COVID-19 vaccination, again in the chat. Facilities located in areas with minimal to no community transmission might elect to use a risk-based approach for determining which residents require quarantine upon admission. Decisions should be based on whether the resident had close contact with someone with SARS-CoV-2 infection while outside the facility, and if there was consistent adherence to infection prevention and control practices in healthcare settings, during transportation, or in the community prior to admission.
Thank you. Okay, Dr. Ogden, if a person experiences side effects from the first dose of an mRNA vaccine, that's Pfizer or Moderna, should they go ahead and receive the second dose, considering the first dose has as good of an efficacy as some single dose vaccines?
Good question. Yes. To get the most protection, you should get the second shot, even if you've had side effects after the first shot, unless a vaccination provider or your doctor tells you not to get it. In most cases, discomfort from pain or fever is a normal sign that your body is building protection. Contact your doctor or your healthcare provider if the redness or tenderness where you got the shot gets worse after 24 hours, or if your side effects are worrying you or do not seem to be going away after a few days. Talk to your doctor about taking over-the-counter medicines such as ibuprofen, acetaminophen, aspirin, or antihistamines for any pain and discomfort you may experience after getting vaccinated. You can take these medications to relieve post-vaccination side effects if you have no other medical reasons that prevent you from taking these medications normally. It's not recommended that you take these medications before vaccinations for the purpose of trying to prevent side effects.
Thank you. So finish the dose, finish the vaccine.
That's right.
Final question for you. So somebody wrote, my husband just tested positive for COVID-19. He was treated aggressively for cancer 2 years ago with chemo and radiation. Should he speak to his oncologist?
Yes, he should speak to his oncologist. Older adults and people who have severe underlying medical conditions, including a history of cancer, seem to be at a higher risk for developing more serious complications from COVID-19 illness. Cancer survivors should speak with their healthcare providers about steps to take to manage their health and any symptoms that may develop.
Thank you so much, Dr. Ogden. Well, this concludes today's discussion. Thanks so much to everyone who joined our call. As you know, a recording of this call will be posted on our weekly partner call webpage, where you can subscribe to future calls and you can find recordings and information about previous webinars. The link is listed on the slide, or feel free to click and copy the link in the chat box. One key note, we will be changing the frequency of these partner calls, and so stay tuned. We will have our next call next Monday, April 26th. The call is titled Keeping Up with Critical Diabetes Care and Prevention During COVID-19. And then following that call, we'll stagger the calls to be a little bit more infrequently, likely once a month, so that we can get you a little more content, and you can take advantage of some of the other sources of information that CDC is producing as well. Until next time, please wear a mask, stay 6 feet apart, avoid crowds, and get a vaccine. Thanks so much, everyone.